Good afternoon, everybody. Good afternoon. My name is Mike, and welcome to our grand round this afternoon, which has been titled Encounters with Grief. I can see that a number of people are joining us as we speak, and we're really delighted to have you here with us. This afternoon, we're going to have something of an informal conversation between the four people that you can see on the screen at the moment, and I will introduce those people to you in just a little while. And that's going to be a conversation around encounters with grief. Recognize that we're living at a moment where, particularly over the last month, many of us have had encounters with grief of various kinds and types, whether that's with the patients we've been looking after, the relatives of those patients, even the colleagues that we work with, and indeed the sense of national grief at the moment as we hear daily about numbers of people who have died. And we want to use this as an opportunity to recognize that that's not easy and that the amount of grief that we're encountering is not usual. And we want to ask, how can we begin to make some sense of it so that we both serve those who we're looking after well and look after ourselves and our colleagues well within that whole process. So that's where we're going this afternoon, and we're delighted to have you with us. There's going to be opportunity to ask questions of our panelists, and you'll see there's the Q&A function on your screen. And if you'd like to ask a question, please do just pop that on in the Q&A box and fire that over. We will aim to anonymize any questions that are asked so that you don't need to fear that your name will be attached to the question, but we will bring the question to the panel as much as we can. Otherwise, if there aren't any questions, that's okay, because there's much to speak about and we're happy just to keep going along the way. I do also want to make everyone aware that we're recording this session. So please just be conscious of that. And that's so that our colleagues can access some of this learning themselves if they're unable to join at this present moment. So without further ado, let me just introduce the panel. So firstly, my name is Mike. I'm a specialty doctor in palliative medicine, part of the team here, and also the wellbeing lead for junior doctors. And I'm going to be hosting the discussion this afternoon, which hopefully means I won't be speaking very much, but my esteemed panelists will be. Can I first of all ask Jane to introduce yourself? Jane, you're just on mute at the moment, so everyone can unmute themselves now. That's fine. Thank you.
It helps, doesn't it? Unmuted. I'm Jane Harris, and it's an absolute pleasure to be here talking about something that is so important right now. We've never lived through anything like this before, and it really is important to me to take part in this conversation, because by sharing stories and trying to find meaning out of something that is so complex really makes a difference. So I'm a psychotherapist, a filmmaker, and 10 years ago my son Joshua died. Which changed me enormously and forced me to address death and grief even more than I had already as a therapist, because that's part of my job, is to address death and grief. So today I'll be talking a little bit about that and sharing some of my journey. 10 years of learning. It's been like doing a fast track or a slow track PhD, whichever way you want to look at it. But I've learned so much through my personal experience, both making films with the bereaved, about what it's like to experience untimely death, and about how you can assist people in their journey.
Thank you, Jane. That's really helpful. Well, we'll hear more from Jane in just a moment's time. Sue, I wonder if you could introduce yourself, please.
Yeah, hello, my name's Sue Edwards. I'm recently appointed into the bereavement nurse post for the trust. Previously been a palliative care nurse for over 10 years, and yes, very much looking forward to this session. Thank you for asking me.
Thank you, Sue. And Anna.
Hi, so my name is Dr. Anna Locke. I've been a consultant at this trust, I think, for 11 years now, and I do hospital and community palliative care. And as a palliative care specialist, we see a lot of our job really preparing our patients and our families for their death, and also helping people process what's happening. So maybe their grief afterwards, although will still be very real, that they have a story and a narrative to make sense of it, so that perhaps their grief is a little bit easier to live with. And what I've really noticed during COVID is actually increasingly we're having conversations with colleagues along a similar line, as we're all dealing with grief ourselves in different ways.
Yeah, wonderful. Excellent. So that's the panel. I must say, we are just delighted Jane is able to join us today. Jane's an external speaker, and we're really glad to have her here. And Jane, I'd like to come to you first, if that's okay. You mentioned that you've had both professional and personal experience with grief. I think you described it as like a 10-year PhD of learning, which perhaps suggests there's always more to learn. I wonder if you could just speak into some of your professional and personal experience.
Yes, I'll start by speaking about my personal experience, because losing your child is something that you never think will happen to you. It's something that happens, and it happens more than we think. But when it happened to me, my world changed in the blink of an eye. I found myself on a planet that I didn't recognize, and I was deeply traumatized. And I think probably a lot of people who've joined today will understand that the word trauma is always associated with untimely death and grief. It's not an unusual term to use, because when something unexpected happens, you're traumatized and you have to adapt. But personally, in the first weeks and months, we functioned purely and simply by having to organize a funeral. We had no choice, and it had to be done. And we'd never done that before. And I think it really taught me so much about what matters when you're traumatized. When you're traumatized, nobody can fix it and nobody can help. Though that's what, unfortunately, or fortunately, whichever way you want to look at it, everybody wants to do. And very quickly I realized that all I wanted was to huddle closely with my family members and check that nothing bad was going to happen to them, because we all felt, in a way, our belief in the world had been crushed, had fallen apart. So we huddled together and we organized a funeral for our son, who was 22. He was on the trip of a lifetime. He was very happy. And as a mother, and I have to speak as a mother, because in a way I lost my role at that point, I was so taken aback, because in a way I'd done the job of parenting. I'd given my son what I felt was good enough routes, and he'd flown, and he was flying, and he was happy. So when this happened, myself, his dad, and his siblings just fell apart. There was something about creating the funeral that really helped us. It was actually a celebration of his life. And what we found we had to do at that point was to model something that said that it was okay to grieve, because Josh's friends were 22 and many of them had never experienced death or loss in their lives. And when we asked them to participate and share their stories, initially they said, no, it's not possible. We can't, we'll follow you. And we said, no, we need you to, and they said, well, we'll cry. And we said, yes, so will we. And I said, but we'll also laugh. And they said, I don't think so. We laughed and we cried and we shared stories and we found out things about our son that we didn't know. And they found out things about themselves that they didn't know. And what was fascinating about it was that after the funeral was over, Josh's friends said to us they felt better and they were almost ashamed to admit that they'd enjoyed the day. Now, what they meant was that with a ritual, there's something about making something real. And if you can make it real, you can absorb it better, because what we all probably know about grief is that if you don't express it, it will find its way out, either physically or psychologically. It will manifest in physical symptoms or it will manifest in psychological forms, whether it be panic attacks or anxiety. And all his young friends said, you know, it's taught us so much about the importance of every day that we live, and we're going to carry him with us. And they have. And 10 years on, it was actually 10 years last week since Josh died. And 10 years on, we've received a lot of communication and messages from those people saying, thank you for giving us permission to talk. Thank you for making films, and thank you for sharing stories and creating meaning out of this dreadful situation. And in many ways, the reason that I'm here today is to talk to that, because every one of us right now is living through something so shocking. So I use the word unexpected. I don't know what else to say, but what do we do when we feel helpless? We'll come back to that, but I think that is at the heart of this talk today, isn't it? That we need to talk about how we can get alongside each other, how we can help each other, and also how we can deal with our helplessness. And just to add, before I hand back to Mike. A few years ago, we set up a charity called the Good Grief Project. And the idea behind that was to create a platform where we could share stories, make films, and create a more comfortable language where people could share and absorb different ways of dealing with death and loss and grief through writing, through boxing, through physical exercise, through yoga. It doesn't matter, but it's about doing. Grieving is often about doing. And if any of you want to find out more about that, the link is on the platform here. But the point about this is that by doing, by being active, and by learning to articulate, however terrified we are, in a way that is helpful to others, is the best and the most we can do. And often that means saying very little, which is a good point to hand back to Mike.
Yeah, thank you so much. I mean, so much already there for us to be thinking about. The idea that that grief needs some direct expression, otherwise it comes out sideways in anxiety or in aggression or all sorts of other ways. One of the things I'm very conscious of is that within the Trust, our encounters with grief have been varied, and we'll touch on some of those different aspects. But one of them is sharing that moment with relatives in ways which are unusual. Oftentimes we like to be able to have people physically present when we're of death, and that's not been so possible. At times it's had to happen over the phone or in personal protective equipment that has made it more difficult for us to communicate in some of the ways we might want to. I wonder, Anna, if you might first of all just speak into some of the challenges that presents, both in terms of doing it well, but also our experience of having to go through that.
Yeah, I mean, I think it's been incredible, to be honest. I think watching what's happening in the Acute Trust, what's really struck me is how a job that used to be very much owned by senior staff. So even teaching medical students, say the mantra is you don't break bad news, it's done by the consultant, and you don't really have to learn how to do this. And watching the wave of COVID as it actually became clear that wasn't even feasible. And I've really seen a lot of very newly qualified staff and different staff, not just doctors, really stepping forward and proactively making contact with families and having these amazing conversations that I see as gifts rather than difficulties. I know they're hard to do. I've done my fair share of them over the years, but probably not to the extent that many of the young doctors, particularly young doctors, are having to do now, one after the other. But actually what I'm seeing is people not seeing that, taking a very active approach, saying, okay, I'm going to own this because I think actually I can help. That actually if a family is informed, they're bereavement. And I don't think people even realise what they're doing, this gift that they are giving people, because I think a family who feel informed will tell me when we see them at home or when we talk to them, actually, you know what, that young doctor, they told me how it was hard for them, they must have been really upset by it. They don't feel that the doctor is the news. And I think that might, as in, causing it. And I think that's a possibility that you might feel if you're having to ring up and break bad news. Actually, you've created the news. And of course, they don't. It's just what's happening. And I've been just so impressed by all the conversations that people are doing and trying to keep informed. I think doing it consistently is hard. We do see gaps, and that's when things don't work out quite so well. But I think this giving people an understanding of what's happened, so if they can't be present themselves, that when they start thinking, okay, how did my mum die? How did my dad die? Was it okay? Actually, it is an incredible gift.
Yeah, there's something that's being expressed here about providing a narrative where that's been missing for people because of restrictions with visiting and what have you, and something of a detachment between understanding we ourselves are not the bad news, we're providing bad news, but we're also providing a narrative that can help to be part of the healing process, even as that news is delivered. In just a moment, I'd like to come to Sue, who can tell us a little bit about the work she's been doing around that. But I'll come to Anna first, and then I'd like to ask Jane something on the back of it.
I mean, a little bit, is that the assumption that it's always bad news isn't necessarily the case. If you've got a frail older relative who you actually have recognised have been dying for some time, and maybe because there wasn't planning, because maybe something fell apart, they ended up in hospital, actually someone after your family member, we're going to make sure they get great care, and not more than they need. That's not, I mean, I know there's a lot of talk about, oh, everyone wants to die at home or whatever, but actually that isn't always the case. I think if we can hear what people are worried about, then sometimes actually the conversation isn't necessarily bad news, although it may still be sad, it might not be bad.
That's really helpful. I think acknowledging that this is significant news, and it needs to be held with the gravity of news that is significant, but it will have different connotations for different people. And you know, our encounters with grief are as varied as there are people on the earth, because we're all of us so different. It's always a different. Jane, I just wondered whether you could talk into what might be key characteristics to be a therapeutic presence at that moment of sharing significant news of the death of a loved one.
Okay, well, firstly, I'll share being on the receiving end, because you remember how news is delivered, bad news is delivered for the rest of your life in many ways, as you remember how good news is delivered. And when we were told about our son's death, my heart breaks now for the 2 young police people who came to our door, who had no training in how to deliver bad news. And it was awful, and it was terrible. And everything that could have, every mistake that could have been made was made because they didn't know how to do it. And I've since given a presentation as a therapist to a packed room of police officers of all levels of responsibility. And what I shared there is what I'll share here, is that, and I always seem to come back to this, we are powerless to fix this. But what we can do is make sure we are robust enough and taking care of ourselves well enough that we can be alongside whoever it is we're delivering the news to. And that, you know, with the best will in the world, there's a sort of knee-jerk instinct to come out with a cliche like, well, maybe they're in a better place, or, well, you know, now they're not in pain. Some people might say that about someone who's taken their life. There's so many cliches that are well-intentioned, but actually what I want to hear and what my clients want to hear is something along the lines of, I maybe don't have the words, but I'm right here, right next to you, right now in this moment, and we'll find some way of getting through this together. I can't fix it. I know it's not for fixing. And in many ways, that makes you feel, both as someone on the receiving end and as a client in therapy, that it's okay. So what you're doing is you're normalizing something that is way from being normal. There's nothing normal about what you're all going through right now, and what so many people go through every day with untimely death or unexpected death. However, as professionals, we have to learn to deal with it better. And as people on the receiving end of it, we have to be able to get support. And I've discovered over the years that I go around with a mask on a lot of the time. Now, it's very topical right now because we're all wearing masks and you're all masked out, of course, all the time. But do we wear a mask to protect others, or do we wear a mask to protect ourselves when we're talking about grief and delivering bad news? Well, I found over the years that an awful lot of people are terrified of talking to bereaved people about their grief, particularly if it's the death of a child. So very often I'd find that people would either ignore or avoid the subject of the death of my son. Or if they asked me, they wanted me to say, I'm fine. In other words, have you found closure yet? Well, as you'll probably all know or may have considered, there is no closure with the death of a child, but there are openings. You live with, I mean, because my child's dead, I don't stop loving him. Because your mother's dead, you don't stop loving her. This is all about, I suppose, from a therapeutic point of view, of learning about continuing bonds and how do we fold our loved ones into our hearts in a less painful way so that we can carry them with us? How do we share the idea that with the passing of time, the edges get less jagged? And with patients that you're working with, how do you support their families to absorb something that is indigestible every time we come back to being helpless and accepting that you can't fix it and being robust enough to face that and not feel, and this is really important, not feel that you've failed? Because I suspect right now, every one of us feels at some level or another, we're failing our patients, we're failing our clients, we're failing each other, we can't take it anymore. But you have to step away from that and seek support. You have to get some kind of supervision, peer supervision, go running, go and scream, whatever it takes, but you mustn't let that be absorbed into yourself and turned into something negative.
Thank you very much, Jane. So that dynamic of being alongside in those significant moments, and of being alongside not as a fixer, but as someone bearing witness to that significant moment. And it strikes me that if we're going to be able to be alongside for our relatives of our patients, then we need to be alongside one another at this moment in time. And I wondered whether anyone would like to speak into how we can be alongside one another in a way that enables us to keep providing the care we want to these significant conversations. Anyone want to? Yeah, Anna, why don't you go first?
I think really the key is really active listening, is hearing people. And that might mean even, I mean, if we're thinking about phone calls, the first question may be being, how are you? Rather than I'm ringing to give you news. Or when you've got colleagues who are upset and distressed, or even they seem to be okay, checking in and asking how they are. And maybe certainly as a consultant, sometimes I will not in a kind of overly deliberate way, but actively discuss what I'm finding hard. And that's something I've done for a long time, but I think actually I'm finding this difficult and naming it. And I think from a point of view of seniors, to model that sometimes it's okay not to be okay, and that it might be, I mean, I spent most of my junior doctor time, I spent a lot of my time as junior doctor in tears in the sleeps, because I'd have given some families some very emotional news, and I would just, the transference would be straight onto me, and I'd go and I'd burst into tears. And actually that was fine. You know, that was, for me, that was just, it all was out and I'd carry on. But actually I think this sort of narrative of we've got to, you know, crying is weak, or that we can't express that something is upsetting. I think if we can just shift a bit from it, and it's certainly, I know there are people who will not want to cry ever, and that is absolutely fine, but having some way of kind of just, because we can't carry all this awful stuff around with us all the time, because we just get weighed down. And I think, you know, loads of phone calls are actually just dealing with upset colleagues. I think just actually acknowledging that it's hard doesn't mean you make it harder. So yeah, that's my thought.
Thank you. No, that's so helpful. The having context where we're able to give expression to our encounters with grief and bear witness to our expressions alongside one another, so that it does not come out sideways with aggression or misunderstanding of one another as colleagues. It enables us to keep pulling together as we have those contexts. So on the subject of being alongside in those moments, I wonder if you can tell us a little bit about all the wonderful work that you've been doing to continue to be alongside the loved ones of patients who have died amongst us over the last 12 months.
Yes, so we are a small service, and we actually got together due to the reality of the high mortality that was happening within our hospital. And myself and a couple of other people that work within the palliative care team and some redeployed nurses set up the bereavement telephone service. And what we do is we manage to contact relatives and carers of any person that has died within our trust from the 1st of March onwards. So we contact the next of kin number that's on Unity, and we just ring up and say, how are you? We exactly ask that question, ask the family how they are, and them, and just listen. We acknowledge the loss they've had, whatever, if that's being a relative, a friend, a carer, a hairdresser or window cleaner. We acknowledge that loss to them and ask who's supporting them, and listen to the narrative of the journey they've had of losing their loved one. And that the main themes that have come from those precious discussions are initially on the first wave was anxiety of the separation, of entrusting the care of their loved one into our care, but not being able to see them. So the last time a lot of families and carers saw their loved one was in the back of the ambulance coming to hospital, and then relying on communication with the ward and departments. And since the introduction of having the iPhones and iPads and being able to include families now in that journey, and visiting for to come see patients at end of life, has made a difference in the theme of the phone call that we've made, and also in bereavement pathways as well that families are moving through. We've heard so many stories of gratefulness for the care that's been given to their loved ones from here, and from that initial call we've been able to offer a follow-on call, and if not, we from that follow-on call we also identified a theme of loneliness within some of the bereaved carers and families. Some people have had lots of bereavements within the families, up to 5 members, and it's acknowledging that isolation and loneliness, and especially with the lockdown, that's enhanced it. And we've been able to have volunteers come to our service here and make ongoing befriending phone calls, offering that ongoing support and just talking about day-to-day things, because that may be the only call that that person has in a week. From that also we can identify where, from those discussions, where people might need extra support as well, and we've been able to signpost onto local resources and offer bereavement counselling support through crews, our local crews as well. So we've been able to signpost and support and do a befriending service as well. We've acknowledged that often sometimes care, some families have experienced different, what they see as not as good a care as what they would think, or difficult situations which they've struggled with. So we can then we send emails, and we try and separate with the family their bereavement to that problem, but also support them in getting answers to questions they may have, which will allow them then to move forward with their bereavement as well.
You said to me, Sue, and thank you so much for sharing all about that, how often what relatives say to you is, when you speak to them 6 or 8 weeks later, they say, I'm amazed you're still thinking of me.
Yeah.
And it's that sense of the trust, still caring, still being alongside, in the form of the conversation you're able to have with some of the loved ones. Is that right?
Yeah, absolutely. It's overwhelming, that the thank yous for the phone calls, even when it's been sometimes later than the 8 weeks, of them just saying thank you very much, I can't believe that as a hospital you're still thinking of us. And they love telling us the narrative of their loved one as well, and the complimentary of the care that they've had and received from any member of the team here in the hospitals, and that's really good to feed that back as well. You know, we like to email when they name staff they want to pass thanks on, because they didn't get the opportunity to. We email the staff as well to say we've had a message of thanks on behalf of that family. The acknowledgement of that loss is the overwhelming sort of thing I think we felt in the service. Yeah, definitely.
Jane.
I was just going to say, what a wonderful service you're offering, Sue, because, you know, the reality is that in the first days and weeks after someone dies, it's almost too shocking. But, you know, to be remembered after, and to feel some level of continuity. And of course, the reality is that for a lot of people, it's after the funeral's over that the profound, unbearable agony of grief kicks in. And that any kind of continuity means the world to people. And to be able to say the name of the loved one or the person who died is amazing. And in fact, we've made a film for the Compassionate Friends, which is a wonderful peer-to-peer support group that I used to be involved, well, I'm still involved with, but not so much. But we made a film for them. We called it Say Their Name, because every bereaved parent we spoke to said, when somebody says the name of my child who's died, it brings a tear to my eye. But it's not a tear of unhappiness, it's a tear of joy that they had the guts, they had the nerve to say the name of that person. So just to be able to say, I've been thinking about Josh, that's my son. You know, that makes me happy personally. And I know that from all my clients and experience as a therapist, you know, to say the name of someone who's died means everything. But it does take courage, because a lot of people will say, well, I'm worried if I say anything wrong, I'll make them cry. It's not you who's making them cry, is it? It's not tears of sadness. It's very often tears of kind of appreciation and relief that it's okay.
Definitely. I think from especially through the work the volunteers have been doing, just gifting their time to hear, the difference they make, because the families the relatives that they're contacting and recontacting every couple of weeks, it just gives the family the opportunity. They feel safe in talking about their loved one, because they feel sometimes that they're burdening other family members by keep talking about it and feeling they should have moved on and perhaps haven't. So it's lovely to hear them have lovely conversations about memories. So I think that's really important. Yeah.
Thank you, Sue. Anna.
And I think when we set this up, because it was mid-first wave, the money was for something else, and we repurposed the money. And in part, it was really because we could see the almost unfairness of the situation, where we had for a long time made these kind of phone calls to people who died under the care of our community palliative care team. And if you're registered with a hospice, this would be quite standard practice. And we thought, actually, you know what, it really isn't on. If you die a sudden, unexpected death in an acute hospital, then actually your need for support is just as valid, if not more valid, because you're probably likely to have less pre-bereavement support. And I think what must be hard for you, Sue, is knowing when to let go of those phone calls, because I know because actually we can't ring everybody forever. And so there's that, but then there are some families we cannot contact because we don't have their numbers. And I think if people could just take away, actually, if we've got their numbers, we've got the next of kin phone numbers easily to find on Unity, people will get this support. If we don't have the numbers, it actually just, then there's another group of people who miss out.
So that's really helpful. And I'd just like to come on to something on the back of that, really. So clearly you're having lots of conversations and conversations where you're acknowledging, coming alongside and listening to the narrative of those who you're hearing from, as well as providing some narrative at times. We talked about that. And I know that for some of the patients I've looked after, it's helped their loved ones to know about some music they were listening to, or a prayer that they might have prayed, or some expression that they made as they had their final days and hours. But I, after having such conversations, clearly it takes something from us as we provide that presence and keep alongside. So firstly, Sue, and then Jane, I wondered if you could tell us, when you put the phone down, having had a follow-up conversation with a relative, what ritual might you have to help you to be looking after yourself after that moment and ready to move on to another moment?
Well, if anybody who knows me knows I love tea, so as you can see, the kettle's always on in here. But what we do, when there's a couple of us here, we're often listening into each other's conversations, and what we'll do is we debrief. We just check on each other and say, we could tell that was maybe a difficult conversation, and just talk it through with each other. So we check on each other, especially with the volunteers as well, and we just do that sort of peer support within ourselves. But we also have we do have reflection as well, monthly reflection meetings, which help us also talk through difficult phone calls that we have that are maybe still in our mind. But yeah, always having the kettle on is always on in this.
So there's something there about our ordinary human needs, having a cup of tea, having a moment where we don't expect of ourselves. We can just go from that conversation to another conversation without any pause, and then having some peer support. So how about you, Jane? Would you like to speak into that at all?
Yes, I think peer support's a fantastic thing, but I also think as a therapist, noticing when I've been deeply impacted by something, and rather than going into automatic denial, which of course isn't what I'm here to do, it's recognizing how painful that is, and then parking it, and then coming back to it at the end of my working day. And then if it's been a really bad day, however little I want to do this, I might go for a run. Because when I want to do it least is when I need to do it most. And I've learned since Josh died, I mean, that's one way that I kind of got through the death of my son, was to go running. And I sometimes find myself going out in a state of numbness, stopping in a field, crying, hoping no one would see me, feeling ashamed, but feeling this huge sense of relief, and coming home and then feeling able to think again. It's discharging some of that built up, pent up feeling. And, you know, it's similar with the working day. You need to debrief, even if it's just to say to someone, oh, you know, that was really tough, or I felt helpless, or have a cup of tea. And recognizing that there's lots of rules around what you should and you shouldn't do. And though rules are helpful, they're not necessarily ideal. You have to have your own toolkit. You have to know what helps you yourself.
Yeah, and we'll come back in a minute to helplessness, because I think that's important. But yeah, that release that you have when you go for a run, certainly in the last 9 months, I've done more running than I had done before. In the last few weeks, more sledging than I think I've ever done, which helped me with a bit of release. I'm not sure it helped all the children who I was bumping into along the way. Anna, I think you've got a question.
Well, first of all, got a comment that was sent to me privately from someone who was bereaved and found that actually knew that they felt the service was amazing and really helpful to them. So that's just a lovely comment. And then we've got two questions that kind of interlink. It's really about almost secondary grief. So the question so in the acute hospital, we are, I'm paraphrasing because it's quite, that we are set up to cure and to make people live, and actually that we might be in part grieving the patient who's died in front of them, but we might also be grieving our failure as a clinician possibly. And how do we help acknowledge that and support our team? And another bit of it possibly is about feeling a little bit guilty about grieving for someone who we might feel we've got no personal right to grieve, we haven't got no connection with them ourselves. So this idea of grieving at a slight distance, but still feeling it very much, and how might we live with that and support each other?
That's such a good question in terms of, you know, the idea around who's allowed to grieve for whom. And I think we need to get away from the idea of a pecking order of grief and pain, that everybody grieves differently, and once again rules don't help. And that, you know, I've given presentations to big organizations where people have said, I don't feel I've got a right to feel heartbroken, but I am heartbroken that my colleague who I hardly knew has died. If any of you have been around people who've died recently, regardless of whether you're close to them or not, it's going to impact on you, because every grief, every death opens up earlier experiences at a psychodynamic level, because we all have histories and we all have our childhoods. And I think that how we have experienced death, loss and attachment as children is impacted very much in the moment now. And that what may seem straightforward, if there's ever such thing as a straightforward death, is never really straightforward, because we have layer upon layer of learning and patterns of behavior. And when we're under stress, we fall back into those positions. It might be that suddenly you're trying to be strong and brave and put on a brave face because your mother said when you were 6, come on now, pull yourself together. And you just want to be available. So I think that, you know, acknowledging that everybody has a right to grieve, and anticipatory grief is really important to recognize. We don't know how someone may be going to die, but we know they're going to die. There's so many levels, so many different issues here. It's massive.
And certainly for me, that kind of speaking to your own personal experience, I'm sure every time I see an older lady from a nursing home, I step straight back into my shoes, standing in a nursing home where my 87-year-old granny was dying. and how I felt in a professional role. And I guess I think about it a lot, and I think I mostly recognise it, but I also flash back to different patients or experiences, and of course our memories change, don't they? But it's very helpful for me. I mean, I'm probably a bit snappy occasionally with some of my consultant colleagues when they're doing things I wouldn't have wanted done to my grandmother. But of course, not everyone is my grandmother.
But that's the point, Anna, isn't it? That you know, there's so many triggers, and I can give a very, very brief example of when my father died, age 98. I thought, that's not fair. He lived to be 98 and my son died at 22. Now, as a therapist, I'm thinking, come on, Jane, pull yourself together. But grief and thought processes are not always well behaved. But, you know, you're allowed to have bad thoughts that might shame you. But of course, the way through that is to give yourself permission to be angry in the right place, to express that kind of emotion that might be disapproved of, where you're no longer the dignified mother who lost her son and seems to be taking it so well. You're a monster. It's okay to behave badly in the right place, and we all do it. And so, Anna, you know, the triggers that are there for every one of us, it's only fair to acknowledge that's just how it is.
Yeah. I think for doctors, we're often thinking we're in a very scientific mode all the time. In hospitals, you know, we're trained to be scientists, and I think acknowledging that we're humans and scientists and that we have our baggage, that it's not baggage, it's just our lives, is really important.
Yeah, absolutely. And I think that, so I think what we've touched on here is the reality that we are having these encounters as professionals, but we're also having these encounters as human beings with our own human story. And we can't park that as if we don't bring that with us to these particular encounters. We do. And part of staying well as we navigate through this time is acknowledging our ordinary human stories that we bring to the table, which will have triggers that might make one situation more difficult than another, for reasons that might not be obvious to us at that moment in time. And I guess because we're having those encounters as both human beings and professionals, that helplessness that we can sometimes feel as professionals can maybe add into the human experience that we're having at that moment. And we think, well, I'm not sure what to do because I feel helpless in this moment. Does anyone want to speak into that sense of helplessness around these encounters with grief? And also perhaps the idea that somehow it's a failure?
Happy to. But Sue, did you want to say something?
No, it's okay, Jane, carry on.
Are you sure? I think that helplessness is what we work with all the time. It's the biggest problem. I mean, when you train as a therapist, the first thing you have to learn is if you can't deal with your helplessness, you're never going to be a good therapist. And I'm not a medic, but I imagine it's a little bit the same, possibly, that you have to acknowledge that you just can't sort some things and you have to let go. And letting go of a problem is really difficult. Actually, in the letting go is an acknowledgement, and that can feel really good for the person who is actually on the receiving end. And I have an awful lot of clients who come to me and they say, oh, I feel so bad. Everyone tells me I should be doing better. And everyone says, are you over it yet? Have you found closure? It's been 6 weeks and I'm still not better. And I say, really, you're doing amazingly. And I say this to people even 2 years after they've been bereaved. It's still early days for a lot of people. 2 years on, it's harder than the first because it's real. It's been absorbed. And if we can recognize helplessness in others, firstly by recognizing it in ourselves, it's such a relief. So my clients always say, oh, thank you for saying that. Thank you, because I felt I was failing. I felt I wasn't doing well enough and I hadn't found closure. Should I find closure? Well, I've said already, closure, no. Openings, yes. Love is, you know, the more you love, the more you grieve. That's just how it is.
Anna.
And I think actually that it's not the helplessness at all, but I do also visibly notice families relaxing when you say something as simple as, this must be really hard. You know, I can see this must be terrible for you, because I'm not making it terrible, but actually, even if you're, you know, and sometimes people actually feel guilty about being upset when somebody who is older dies. You know, why should I, you know, he's had a good life, I'm still upset. And, you know, and actually just saying, you know, I would find this upsetting as well, or sort of acknowledgement. It kind of helps people feel that, you know, because we can't empathise with everybody, as in, but we can. There's some things that will show that we're trying. We're not saying I understand your grief, because I cannot understand anybody else's grief. I can have kind of, okay, my grandmother's also died, but I haven't had a 22-year-old son die. But if I said, this must be awful for you, I could really see how difficult this is. That would have Jane, it has a feeling people need to be looked after, and there are we can't control everything. We are helpless in the face of people's grief, but actually there are things we can do that make it feel like we are alongside them.
Yeah, well, I'd like to come directly onto that actually in a second. It strikes me that there's something then about recognising that something can't be fixed and that it's not our role to lift the burden, because if the burden feels like I'm supposed to be fixing this but I can't, I'm helpless, then until we recognise this isn't something that's to be fixed, this is something, as Jane has said before, to bear witness to, that just changes the focus. Jane, you mentioned earlier, and there's a question that came through about this, about how, in your experience, your personal experience, police were unprepared to be able to be alongside at that moment. And maybe some of us feel unprepared at times for what's being required of us. What advice would you give about how we can be alongside in that moment in a therapeutic way?
I think therapeutically, it's really important to breathe. If you stop and take a moment before responding, and if you think about it, you really are helping yourself by acknowledging that you really are not that powerful that you can sort this, but you are powerful enough to be able to say that. And therapeutically, that really offers huge relief. And I found great relief as well as a bereaved parent being on the receiving end of that. You know, people might say, people have said to me things like, well, you know, some things are meant to happen. And I've been enraged and furious. That was in my early grief when I was very badly behaved. Somebody might say to me, I don't know what to say to you. That feels good. I don't have the words. That feels lovely. People might say, I haven't been able to come around and say hello to you. That feels great. So it's really just about finding language that's comfortable enough. And as a therapist, I know time after time, I'm reminded constantly of what it means, the simplicity of being able to say to someone who's recently bereaved, I'm so sorry, just being silently present, and actually just eye contact if it's possible to have eye contact. And right now it's not. It's really difficult. Doing things via telephone is harder than ever because you're actually speaking into a void, but you have to tune into that as well. There's ways around that, but it's extremely challenging, more challenging than it's ever been before. Shifting away from rules though and stages of grief.
Yeah, that's
every
helpful.
Individual is different depending on their early history.
One of the comments that comes through is that the sense of helplessness we can sometimes feel can give rise to almost an anger about our inability to control or fix the situation, which can then in turn lead to blame and even self-blame, which maybe is a form of, if the grief is not given its expression, then it comes out sideways and some of those different things. How do we navigate what we're going through at the moment such that we don't see it as failure or blame, but recognize it as rather a situation that we have been forced to encounter, as it were, the pandemic, and one in which is a challenge for us all, and we need each other to be able to get through it the best we can. Anyone want to speak into that? Anna, I'll come to you first.
I think the teams where I see it really working very well is where there's acknowledgement that it's tough, where there is shared decision making. So, you know, the perception that we are in charge of when someone dies, relinquishing that, and everybody's voice being heard, so that nobody feels that they're responsible for someone dying. And obviously we all have very many different frameworks about that responsibility. And actually maybe taking a moment when someone has died to think about as a team how that was. And we in the palliative care team, you'd think we were brilliant at dealing with death and dying, and we're all absolutely fine with it, but we realized that we weren't actually talking about people who had died under our team in a meaningful way. And we now have our own learning from deaths meeting where we actually acknowledge sometimes when it was really hard and when perhaps we failed in our eyes, but of course actually the reality is often we've always done the best we can, it just didn't always work out. And actually that has been and we discuss things that go well and things that don't go so well, and sometimes we invite other people in to talk about it. And it's actually been revelatory for me, and actually been an amazingly cohesive thing for our team. And I know in the acute it's hectic and there's lots of people going on, but there will be opportunities and moments to talk, and whether that's at a board round or in a mortality meeting, whatever. But I think seizing those moments to acknowledge and to think about it, and we're in a big picture here. This is not people's fault. We're all doing the best we can.
Yeah, I think some of the research that's come out from the practitioner health program recently has been the importance of people feeling valued. One of the things that can make it unbearable is if, despite trying your very best, you somehow feel less valued than you need to. And so taking it upon ourselves, all of us as colleagues, to look out for things that we can vocally value within the organisation and the care that's being provided. The power of encouragement being about putting heart into people. Can I just come to a question that's come through? This is for you, Sue. This is about the fact that more recently we've had an increasing number of people who have died in ED, and our wonderful staff in ED have been dealing with that and navigating that situation. Are patients who die in ED, do their relatives also get the same follow-up as patients who die elsewhere in the trust?
So we realised that is an area that we need to get that information from. And we realised then that, yes, we could see that A&E were having so many deaths, especially now. And yes, so we're working with the mortuary at the moment. We're working out if families are getting support through via the coroner's route. So it's an area of work that we'd like to look into now in the future. And I'm trying to make contact, as I'm only recently in post, but would love to make any contact with anybody in A&E to see if we can work out if there's a better route of contacting those families who don't go down that coroner's route. So we're just trying to network at the minute to find out how families get support in that situation.
Okay.
Yeah.
So are you happy for me to put in the chat your email address, so that if anyone wants to get in touch with you, then that can happen?
Yeah, absolutely.
Because my understanding is that your commitment is to seek to contact the family of anyone in the trust who has
any loss. Yeah, a loss is a loss to a family. So yeah, anyone. So but happy, yes, to try and network and see if we can reach more people.
That's so fantastic that you're doing that. And I think that, to come back to what Anna said as well, bearing witness, what Mike said too, we've all said, bearing witness is everything in this, isn't it? And as a filmmaker, I think what we try to do is to share stories and help people to walk in the shoes of others who've been through something. Because if you're brave enough to step into the cinema and watch our films, you will bear witness to story after story of people saying, I just want you to listen. I just want you to hear. I don't want you to do anything else. So when we approached people to take part in our documentary, we weren't surprised, but everyone else was surprised. Everybody said yes, and nearly bit our hands off, because nobody wants to talk to the bereaved about their grief, particularly if it's the death of a child or an unexpected sudden death, which is very topical right now, time of COVID. So bearing witness helps everybody. And we called that film A Love That Never Dies, and it's available on Amazon Prime to watch, because the reason we called it that, the clue's in the title of the film. We don't get over this. We don't get over any of this. We're not going to get over COVID, but we're going to learn to live with COVID. We have to. And the only way we can do that is if we bear witness to each other, we're kind to each other, we support each other. And what a challenge when you're doing the work you're doing, all of you. You know, it's amazing. I mean, the stresses from someone who's a porter, or, you know, every single member of staff is facing the impossible right now, and is going to need support. And the bereavement epidemic, you know, there's going to be such a lot of grief that's going to need dealing with in the future.
It's important to remember that a lot of people's grief is okay. If you've given them the bad news, it's like most people it's actually more about their community, their neighbours, their families than professionals. And for many people, bereavement is actually about their families or their neighbours, and many people don't need professional support. Many people need to know that we've done the best we can and they will process their grief okay. And then I think that's a really helpful thing for, you know, that it's a lot of people who ring say, you know what, I'm all right, don't they? They say, you know, thank you, but I'm doing okay. We're pulling together, and, you know, and although at the time it might have felt like the worst thing ever, you know, and people find, it's back to narratives, find a story to make sense. And that's not a fiction, it's their reality.
Wonderful. Well, we're drawing to a close now. So one of the things that I want to just mention is that as a trust, there are many different avenues of support that are available to people in recognition this is a really hard time for all of us. And those sources of support are communicated in the staff bulletin. We're also going to put a slide on here which will give you some details around some of the avenues that can be taken in order to access support through our occupational health and wellbeing service and through the sanctuary and various other ways as well. And of course, we all have a commitment to one another, to support one another, which involves looking after our physical needs, food, drink, rest, using the rest areas that are available, looking after our emotional and psychological needs, having these peer support moments where we can tell our stories and have those stories validated. But for some of us, we're just going to need some extra professional input, and that's okay. That's to be expected. And there are counselling services that can be accessed through the trust and through the occupational health department. And we're also looking at what kind of provisions might need to be in place as we move forward, because we want to move forward together, to move forward as well as we possibly can. Can I ask Jay, any closing comments you might want to make?
I suppose I'd say that, I mean, it's been fantastic to be able to take part in this, but I'd say that, you know, very often death ends a life, but it doesn't end a relationship, and that we need to remember that, and that as the years pass, grief can really escalate, and some people are okay, other people are not, and that to check in on people, whether it's colleagues who've experienced a bereavement, in fact, very importantly with colleagues, who may be friends or not, but to check in on people on the anniversary of a death, for example, and to give them space and time to be experiencing that again afresh. You know, I think we have to normalize the levels of pain and how unpredictable they are. So to step away from rules, acknowledge that, you know, there's lots of theories out there that are fantastically useful, but take the theories and be creative with them. Don't get stuck on the stages of grief. Recognize that the stages of grief can just, you know, come in at all different levels, but finding meaning is as important as anything else in the suffering and pain and the work that you're doing.
And can I say thank you, Michael?
Sorry, Anna. I was just going to ask whether Sue had any just last message you might want to share, and then I'll come back to Anna.
Yes, just let you know, we're based in the Brian Knight Suite at Sandwell. Our details will be on the slide, but the door's open, the kettle's always on here. Anybody's welcome to contact us via our phone number or just drop in. for just for a chat. That's what we're here for, and to let you know if you need any bereavement resources or other signposting to support, just also give a call and let us know. Thanks, Mike.
And our wonderful colleague Mary Causer has said same for chaplaincy. So just know there are people there, and we just want to acknowledge that as well as the encounters of grief we've had of relatives and of our own grief with looking after patients, also our esteemed colleagues, and we know there's had to be some very sad news about that, and we want to just say we want to be available as a trust with all sorts of different resources to help people through that moment, to recognise that that there's a sadness that comes for all of us at that moment, but that for particular people that might be more acute, and we just want to ensure that the support is there and is available. Anna, did you want to share anything?
Yeah, I wanted to say thank you to our audience. I've been having some really lovely, just reflective comments coming through that perhaps weren't for sharing with everybody, but I can really see what a tough time everyone's having. And I also want to say thank you, Mike, for organising this. We so value you as our wellbeing lead, and you have been single-minded in the fact we needed this session, and I think you're completely right. And you have piloted us well, so thank you.
Many thanks. Well, thank you so much, everyone. Thank you so much to Jane for joining us. Do you want to say something, Jane? You're just on mute.
I was just going to say, yeah, thanks, Mike. It's really so special and important that you all do the work you do. And if anyone wants to follow up or to ask me anything, I'm very happy for people to do that via the website. And the details are on the holding card at the beginning or the end. But thanks, it's really very special to be able to talk like this with people.
Thanks for having us. Okay, I'm going to put those slides on now so that if you do want to take note of any numbers or websites, you can. But thank you so much, everyone, for joining us.